Okay, so we are going to have our next session now. നമ്മൾ അൾട്ടിമേറ്റ്ലി ഇതൊക്കെ എന്തിനു വേണ്ടിയാണ് ചെയ്യുന്നത്? പേരൻസിനെ കുറച്ച് കംഫർട്ടബിൾ ആക്കാൻ വേണ്ടിയാണ് ചെയ്യുന്നത്, അല്ലേ? നിങ്ങളുടെ ഒരു പ്രധാനപ്പെട്ട ജോലി പേരൻസിനെ കംഫർട്ടബിൾ ആക്കുക എന്നുള്ളതാണ്. അവര് എന്തൊരു സ്ട്രെസ്സിലൂടെ ആയിരിക്കും കടന്നു പോകുന്നത്. ഒട്ടും സുഖകരമല്ലാത്ത ഒരു വാർത്തയാണ് അവരോട് പലപ്പോഴും പറയേണ്ടി വരുന്നത്. നിങ്ങളുടെ കുട്ടിയുടെ പലരും സാധാരണഗതി ഇപ്പോഴും പറയുന്നത് നമ്മളോട് ഹാർട്ടിൽ ഹോളുണ്ടെന്നാണ്, അല്ലേ? അപ്പം ദ സ്പെക്ട്രം നിങ്ങൾക്ക് ആലോചിക്കാം. സാധാരണക്കാർ മുതൽ എത്ര വലിയ ആളാണെന്ന് പറഞ്ഞാലും, എത്ര എഡ്യൂക്കേറ്റഡ്, ഇനി ചിലപ്പം അച്ഛനും അമ്മയൊക്കെ ഡോക്ടേഴ്സ് ആയിരിക്കും, അവർക്കിതൊക്കെ പഠിച്ചതാണെന്ന് പറഞ്ഞിട്ട് കാര്യമുണ്ടോ? സ്വന്തം കുട്ടിയുടെ കാര്യത്തിൽ ഇങ്ങനെ ഒരു കാര്യം കേൾക്കുമ്പോൾ അവർ ഭയങ്കര സ്ട്രെസ്ഡ് ആയിരിക്കും. അപ്പോൾ അതിനെക്കുറിച്ചാണ് അടുത്ത ഒരു സെഷൻ. എന്തൊക്കെ കാര്യങ്ങളാണ് ഒരു കുട്ടിക്ക് ഹാർട്ട് ഡിസീസ് ഉണ്ടെങ്കിൽ, അത് പറയാം, ഇത് കഴിഞ്ഞിട്ട് അവസാനം പറഞ്ഞാൽ മതി. ഓക്കെ, അപ്പോൾ നമ്മളൊരു ഒരു കുട്ടിക്ക് ഇങ്ങനത്തെ ഒരു അസുഖമുണ്ട് എന്ന് അതിൻ്റെ പേരൻസിനോട് പറയുമ്പോൾ ഉണ്ടാകുന്ന പല വികാരങ്ങൾ, ആ വികാരങ്ങൾ നമ്മൾ മനസ്സിലാക്കിയാൽ മാത്രമേ ആ വികാരങ്ങളോട് നമുക്ക് എങ്ങനെ പ്രതികരിക്കാൻ പറ്റുമെന്ന് നമുക്ക് അറിയാൻ പറ്റത്തുള്ളൂ. അപ്പോൾ അതിനെക്കുറിച്ചാണ് ജെഫ് നിങ്ങളോട് പറയുന്നത്. എനിക്കൊന്ന് നിങ്ങൾ ജെഫിനെ നേരത്തെ കാണുന്നുണ്ടായിരിക്കും. തിരുവല്ലയിൽ നടന്ന നമ്മുടെ ആദ്യത്തെ സെഷനിൽ ജെഫ് ഉണ്ടായിരുന്നു. അന്ന് എനിക്കൊന്ന് ദൂരെ നിന്നായതുകൊണ്ട് അന്നത്തെ നമ്മുടെ ടെക്നിക്കൽ പല റീസൺ കൊണ്ടും ജെഫ് പറഞ്ഞൊന്നും ചിലപ്പോൾ നിങ്ങൾക്ക് കേട്ട് കാണത്തില്ല. പക്ഷേ ദിസ് ഈസ് അനദർ ഓപ്പർച്യൂണിറ്റി വി ഹാവ് ജെഫ് വിത്ത് അസ്. അദ്ദേഹത്തിൻ്റെ വളരെ നാളത്തെ എക്സ്പീരിയൻസ് ഇത്തരം പേരൻസുമായിട്ട് ഇൻറ്ററാക്ട് ചെയ്യുന്നതിൽ, ഇത്തരത്തിലുള്ള ആളുകളെ ട്രെയിൻ ചെയ്യുന്നതിൽ, പ്രത്യേകിച്ച് നേഴ്സ് എഡ്യൂക്കേറ്റർ എന്നുള്ള രീതിയിൽ നേഴ്സസിനെ, പല രാജ്യങ്ങളിലെ നേഴ്സസുമായിട്ട് ഇൻറ്ററാക്ട് ചെയ്ത് പല രാജ്യങ്ങളിലെ നേഴ്സസിനെ ട്രെയിൻ ചെയ്ത്, പ്രത്യേകിച്ചും ഇൻറ്റൻസീവ് കെയർ യൂണിറ്റിലെ നേഴ്സസിനെ ട്രെയിൻ ചെയ്യുന്ന അമ്മമാരോട് എങ്ങനെ സംസാരിക്കണം. നിങ്ങൾ PD മെറ്റീരിയൽ കണ്ടു, അല്ലേ? PD മെറ്റീരിയൽ ഡെവലപ്പ് ചെയ്തതിൽ ഇൻവോൾവ് ചെയ്ത ഒരാളെന്നുള്ള രീതിയിൽ ഒക്കെ വളരെയധികം എക്സ്പീരിയൻസ് ഉള്ള ഒരാളാണ്. അപ്പോൾ അതാണ് നിങ്ങളോട് ഷെയർ ചെയ്യാൻ പോകുന്നത്. പല സിറ്റുവേഷനിൽ പേരൻസുമായിട്ട് പല കണ്ടീഷൻസിൽ എങ്ങനെ ഇൻറ്ററാക്ട് ചെയ്യണം, എന്തൊക്കെയായിരിക്കും അവരുടെ മനസ്സിലൂടെ പോകുന്ന കൺസേൺസ്, അതെങ്ങനെ നമുക്ക് പരിഹരിക്കാം എന്നുള്ളത്. So I welcome Jeff session. I hope it will be a wonderful session for them.
Thank you. Good afternoon. I hope everyone enjoyed ice cream, right? I'll talk about the experience or the challenges the patients face. The challenges the patients face, the parents face, the parents of children early, and really they continue throughout the child's life. So it's a very long experience, a very long time that parents have challenges, many things to deal with when they're caring for their child. So the challenges start early. The challenges, the difficulties that parents face start early. Generally it might start as after prenatal ultrasound, when they're first informed that there's something abnormal, something not normal with the ultrasound, that the child may have a heart defect or other defects, or other defects. It may start with at birth, when the doctor first tells the parents that maybe the child has something's not normal. There might be a defect here. So that might be when the challenge starts, the first time the parents find out, and parents have to begin to deal with the concerns. Maybe at a pediatric ICU, when their child is born, but something's wrong, they go to ICU, pediatric ICU, newborn ICU, and that's where the parents may first find out there's a congenital heart defect, or that something abnormal. Or maybe later would discover a murmur and very early in the baby's life that the parents first find out that their child has a congenital heart defect. So the challenges start early in the child's life, and early in the experience of parenthood. And so the parents have to deal with the initial diagnosis, the preoperative period, the period before surgery or before whatever procedure is done, hospitalization, and recovery. So the parents have to deal with all of those things. So there's a period of kind of compacted stress, a period of intense stress before surgery, while they're waiting during the procedure, and afterwards too. But the point that most of the articles raise is that most of what's in the literature, what's written about the parents' experience, is that the parents are concerned throughout the child's life. It doesn't end. Even after a surgical procedure has been done, the healing has been good, the healing has been successful, the child might be resuming normal activity, everything is going well, but the parents are always, often in the back of their mind, they're worried that something could still go wrong, even long after things have been improved, long after the recovery. The parents still often have a sense of worry, still have some fear, even after that long after things are fixed. So I would say it's a lifelong experience for the parents, a challenge. They're always concerned. So initial response to the diagnosis of a congenital heart defect for the children is often some of the same things that are written about when adults receive a terminal prognosis, are told that you have cancer, and the reason that people first kind of have shock, they don't understand, they can't comprehend shock, and then maybe next denial. My child is okay. My child's okay. They're denying it. They're not accepting that. And then later, when they have some time, then it's often a grieving. They feel like they lost something. In this case, they lost their dream of having a perfectly healthy, perfectly normal child. And they're grieving, and they're sad about that that's something they lost. So first, shock, kind of not believing, just not understanding. Then denial. It's like, no, this isn't true. This isn't happening. I don't believe it. I believe my child's healthy. I think there's a mistake. I think the doctors are making a mistake. That denial. And then finally grieving when they do understand, when they have some time, and now they're sad because they feel like they lost something. They lost their dream of having a perfectly healthy, normal child, and that they have many more things to deal with now. So shock, denial, and grieving. And these are a couple of responses. This is one from Iran, from an article published in Iran, but 7th month, when my child was told I had a heart problem. I became very upset. I didn't know what to do. I couldn't stop crying. So when she realized it, she was grieving. She couldn't stop crying. And here's another person that said, I always dreamed of having a good, healthy baby. And that's what her expectations were. And that's what pretty much all parents' expectations are when the woman becomes pregnant. And the dream and the expectation is that everything will be perfect. And now it's not in this case. If the suspected coronary heart defect was found on ultrasound, on a fetal ultrasound, sometimes if it's regarded as being critical or severe, the parents are often counseled. And often they have to face a choice. Maybe the doctor will say that you have the choice, you can terminate the pregnancy, you can have an abortion, and that's a choice. or you can continue with the pregnancy, and your child will probably have a significant, a severe congenital heart defect, and that they have to make that choice. And that's often a difficult, I mean, that would be a very difficult choice for anyone to make, to say, do I go ahead? Do I continue with the pregnancy? Do we continue with it? And some of the risks that that may involve, or do we have an abortion? Do we terminate the pregnancy when there's still that opportunity, and what to do? And that's probably a huge decision that people don't expect to have to make so early. They're just waiting for the baby to get bigger, the pregnancy to go through, the pregnancy to continue. But now here, early in the pregnancy, they have to make this really momentous, really major decision. So that's a huge challenge for people to do. And for the father and the mother to agree on the decision, that's also difficult. And often relatives will give different advice. Maybe relatives will have different ideas. Not continue with the pregnancy, they worry how the children, will this affect children, and other direct second what did I do? Was it my fault? Is it something that I don't have? Is a father can also think that, and that the father had something to do with causing the congenital heart defect. Maybe asking some of the same questions that the mother might ask. You know, what did I do? What did I do? What did I do wrong? How did this happen? And am I responsible for this happening? So both the mother and the father might have a sense of guilt, and that's something that they have to deal with. Child survival, though, of all the concerns, all the challenges that parents have, the major challenge, and the challenge that they have from the minute the child is born is what can they do to make sure their child lives, that their child survives, that they, and they didn't see it. They didn't see it, and the child didn't get help until it was too late because they weren't observant enough. They didn't watch carefully enough. They didn't see the thing happen. What if I miss something important? Sometimes they look at their baby quickly, and they look at their baby quickly, and they think, the baby's not breathing. Is the baby stopped breathing? Is the baby still breathing? Is the baby dead? And they have to, every time they might look at their baby while their baby's sleeping, they think, is the baby still alive? Just the fear that the child could die suddenly. Is the baby still breathing? What could happen if I made a mistake with the medications? If I'm giving my baby medications before or after the procedure, what if I made a mistake? What if I gave an overdose? I'm responsible. What giving medications that could affect the baby? And also wondering, will there ever be a time that we don't have to worry? Will there ever be a time in the future of this child that we can just relax, that we don't have to worry? And parents being parents, pretty much as parents, I think we always worry. We're never done being parents, and we're probably never done being worriers. Even though the situation might be in really good shape, I think parents always are parents, no matter how old we are, and how old our children are, and how well our children are doing. So parents will always be worried. Discharge to home. Some of the things people said is, I'm the one that's responsible now. I'm the one. We've had so much help before. We've been in the hospital, surrounded but now I'm the one that's responsible. I have to do it. I'm the one responsible. It's me, or it's us. It's the mother and the father. But now we're responsible, and all of a sudden we have a share it while we're in the hospital. Other people were doing it. Other people were helping us. So they feel like they're the people responsible for the baby's survival. And one of the things that people said in the interviews was, it's a pretty lonely place. All of a sudden they feel like they're very much alone and very responsible for so much. Pain from the hospital and still experiencing significant pain. Now the parents feel like they have to control the pain. They don't have all the same resources that the hospital had. So pain control can be one of the first challenges for parents once they come home, once a child comes back to their home. The parents don't have the resources, don't have the same medications, generally don't have many resources as we do in the hospital, as the hospital staff has, to control pain. So feeling solely responsible, this is a quote, I think this is from the UK, from an article published in the United Kingdom. Hardest time in my life was passed besides this child with her illness and treatment. Nobody has helped me, but at the end there's me and only me. If someone wants to help, it is for a while and then they go. The two of us are alone with each other. So the person feels like, even though some people come and help, they only help for a little short time, then they go. And in this case, maybe the mother that was quoted, maybe the mother wasn't getting very much help from the father in this case, too. So mother felt very much alone and very responsible. And this is where, as an RBSK nurse, you can help tremendously insofar as making sure people know that they're not alone, that you're there, you're coming to their home, you're supporting them, you're helping them, you're available, and you're coming, and you're going to come back again too. You're going to come back, you're going to continue to be with them, and you'll be the people that will be really the key person that will help them through the very difficult time. And probably the person they'll feel most comfortable with asking questions. Generally, parents are pretty comfortable asking nurses questions. I mean, we're taught to communicate, taught to be very free, taught to be very approachable, non-intimidating, and so we're generally the people that parents are comfortable asking questions. Sometimes I remember working in the ICU, and the doctors would come and explain, I thought give a very good explanation, very clear explanation, but then when the doctors were done on rounds, and you're with the parents and the child, and you kind of ask the parents, you know, what happened or what's their take, I think sometimes they need reinforcement too, because was it Peter? Someone just mentioned that, like when people first hear things, they only hear about 50%. So we can do a lot of reinforcing, clarification, evaluation of the parents' understanding in our role in the parents' home. This is a quote from Minnesota, from Adriana and my home state. Thank heaven the help we needed was there for us. We are very grateful for everything these nurses did to help Charlie get the care that he needs. So that was a program from Minnesota. But I think maybe Peter and I mentioned that we're quite impressed, very impressed with what's being done in Kerala, and sometimes we think it's more, more organized, more complete, more thorough than we see at home. So the demands, isolation, something experienced by the parents, caring for a vulnerable child 24 hours a day, 7 days a week, no holidays, no days off, really no vacations, leaves little time for social activities. So maybe before the couple, before the mother and the father had the child, they had a very active social life, maybe a lot of entertainment, going out for dinner, meeting friends, whatever. And now all of a sudden, now quite quickly, a lot of that has come to an end. And even if they have the chance of someone else caring for their child, they're often very nervous, very worried that maybe I better stay home. Maybe we better be with our child. Maybe we're not comfortable with someone else taking care of the child. Maybe we need to be with them. So lack of contact with friends and relatives, little time for previously rewarding activities, so that their social life has really gone down, has really become very little, very diminished, very constricted social life. And here's a quote from the UK. Loads of mums formed their friendships at that time. I was left behind because of his needs. So many new mothers form friendships with other new mothers. This new mother with a child with a congenital heart defect, as with other new mothers, and they don't make friends the way new mothers often make friends with the new mothers. They don't have that chance. Preventing a child from people with infections, and that exacerbates isolation too. If they feel like they can't take their child to a social event, something, they feel like their child is too vulnerable, too weak, that makes the parents even more isolated. So the parents are often appropriately protective, sometimes maybe too protective, of preventing their child's exposure to people that could be potentially infectious. So that makes it, as parents have said that they feel reluctant, they're afraid to go to the clinic, because when you take your child to the clinic, they'll be exposed to more people, more potential infection to the clinic. I felt it too risky to go to the clinic with infections. Second greatest stressor, and when people, usually number two is nutrition, adequate nutrition, and adequate nutrition to make sure that there's growth, that the child, parents can become discouraged if their child's not growing and developing it at a normal rate. Maybe parents often do a lot of comparison. So, oh, my child didn't start walking until he was 1.5 years old. what's the matter with my child? Or you compare children, you compare. And so far as growth and development, often that growth and development is going to be somewhat delayed. Maybe the father can't work anymore, or the father can't work as much. And from the income is less, just because of the demand of care. Cost. So finance, even in a, there could still be financial concerns. Dynamic stress, sometimes spouses will feel, the husband might feel neglected, the mother might feel neglected by the husband, that they feel like they're not getting the attention, that they're not getting the concern that they used to get before this of all how come more time to prepare. So the sooner they learn, more time to prepare, and they can do better. But the incidence, this is from the Netherlands or from Holland, and this is 30 to 80% rate of parental distress, what they call parental distress. So very high rate. 40% of the parents, they say, have a need for psychosocial care, so I'll have a care need. Up to 30% of parents have what would be called post-traumatic stress, post-traumatic stress disorder, post-traumatic stress, so very high incidence. And about 25 to 50% of parents, probably heavier with mothers, but both parents with depression. So major mental health issues that parents face when they have a child with congenital heart disease. And even with a healthy newborn, postpartum depression is quite common. So it's very, high incidence, even in normal circumstances, even with a perfectly healthy baby. But that just goes up with the stress, meeting the special needs of a child with congenital heart disease. That becomes even higher. Some reports rates of depression as high as 50%. So the parents, particularly the mothers, are dealing with a very high rate of depression. And that's something for us we need to support these parents. Long-term with children with congenital heart disease or any chronic disease have a higher level of anxiety, stress, and depression. And the child can refuse to take medications, resist to be seen by a doctor, insist they want to do everything other children can do. They resent any restrictions they have, and sometimes if they do have restrictions, it's hard for the parents to deal with that restrictions because the child doesn't want to be told what they can't do. The child never wants to be told you can't do this, you can't do that, you're different. Children don't want to be told that, don't want to deal with that. And one child said, I can't play in school at all. I should just sit alone in a corner, just feeling very discouraged that he couldn't do what all the other children could do. So the children will have issues. The children will have challenges along with the parents. And then another issue, another challenge is for the parents, should they have another child? Do they want to have another child? Should they plan on having another child? Or should they not have another child? Should this be their last child? Maybe their first and only child, or else at least their last child. The parents have to make a decision that's quite difficult. They wonder, okay, if we do have another child, will this child be normal? Or will this child also have defects, maybe congenital heart defects? So what will happen? What will happen if we decide to have another child? Do we have enough time to care for another child? Our time is we're spending so much time. Do we have time to care for another child? And what if we had two children with congenital heart defects? Could we cope with that? Could we deal with that? It's so hard to take care of one and meet the needs of one. If our next child had congenital heart defects, could we still cope with that or not? But finally, I think when I was doing this program, I was saying everything is so kind of sad, so kind of negative, so high rate of depression, so things are so bad. But the thing that a lot of the articles said that, with all these challenges, parents still face the challenges, they meet the challenges, and parents have resilience. So resilience is something that parents show. They have challenges, they have multiple challenges. They have one challenge after another, but they can deal with them. And in that case, the person is holding up the last falling block. They're strong, they can deal with the challenges. And on the bottom, strong enough to lift elephants. Have you seen that, Peter, before? Parents strong enough to lift elephants? Not literally, just figuratively, I guess. But parents can survive. So parents are successful for caring for their child. They show remarkable resilience, the ability to adapt. So human beings are very good at adapting, and parents are very good at adapting. So they're having all these challenges, but still they can meet them, and they can still be successful. And the love of their child helps them deal with all these circumstances. So the love of their child, the love that the father and the mother have for their child, allows them, enables them, empowers them, and provides the resilience to deal with the situation, to deal with care of their child. And so it's clear parents have many, many challenges, but we, or you, as RBSK nurses, visiting in the home, establishing relationship, continuing that relationship, can help them make it through those challenges. So, thank you.
Thank you, Jeff, for a wonderful session. I don't know how much being transacted, whether there was any language barrier, but emotionally, this would have been one of the best sessions we ever had. This is one of the most challenging area that the nurses should work on, and I think Darshana will be telling some little bit on this based on some of the real life stories, mentioning especially on certain parental challenges. So pardon, Peter, we'll have a short 10 minutes by Darshana, and then we'll come back to you. എന്താ നിങ്ങൾക്ക് കിട്ടിയത്? ഉറങ്ങുമായിരുന്നോ? ഒന്നും മനസ്സിലായില്ലയോ? ഉറങ്ങിയില്ല. എല്ലാവരും ഇങ്ങനെ പിടിച്ചിരിക്കാണ്. മുഖത്തെ മസിലുകളുടെ ബലം നീരാവുമെന്ന് തോന്നുന്നു വൈകിട്ട് വീട്ടിലേക്ക് ചെല്ലുമോ. ഓക്കെ, അറ്റ്ലീസ്റ്റ് നിങ്ങൾ ആ സ്ലൈഡ്സിലൂടെ പോയെങ്കിൽ പോലും കുറേ കാര്യങ്ങൾ മനസ്സിലായെന്ന്. ആദ്യം പറഞ്ഞ പ്രത്യേകിച്ച് ചില കാര്യങ്ങളുണ്ട്. ഒരു ഡയഗ്നോസിസ് എങ്ങനെ ഡയഗ്നോസിസ് അവരോട് റിവീൽ ചെയ്യുമ്പോൾ ഉണ്ടാകുന്ന പ്രശ്നങ്ങൾ, എസ്പെഷ്യലി ഒരു പ്രീനേറ്റൽ ഡയഗ്നോസ് ഉണ്ടായിരുന്നു, ആൻറ്റിനേറ്റലി ഒരു ഡയഗ്നോസ് ഉണ്ട്, എന്നിട്ടും അവർ കണ്ടിന്യൂ ചെയ്തു, പ്രഗ്നൻസി കണ്ടു ഡെലിവറി ചെയ്തു, കുട്ടിക്ക് ഒന്നും ചെയ്യാൻ പറ്റാത്ത അവസ്ഥ പലപ്പോഴും നമ്മൾ എൻകൗണ്ടർ ചെയ്യുന്നതാണ്. നിങ്ങൾ എത്രത്തോളം എൻകൗണ്ടർ ചെയ്യുന്നത് എനിക്കറിയത്തില്ല, ഞങ്ങൾ എൻകൗണ്ടർ ചെയ്യുന്നതാണ്. കേസ് കൊണ്ടുവന്ന് രജിസ്റ്റർ ചെയ്യും, ഒന്നും ചെയ്യാൻ പറ്റത്തില്ല, സിംഗിൾ വെൻട്രിക്കിൾ, പാലേഷൻ പോലും ചെയ്യാൻ പറ്റാത്ത കണ്ടീഷൻ, PG1 ആയിരിക്കും ബേബി, PG1 വിഡ്രോ ചെയ്ത് കഴിഞ്ഞാൽ കുഞ്ഞ് മരിക്കും, അല്ലെങ്കിൽ വെന്റിലേറ്ററിലായിരിക്കും, വെന്റിലേറ്റർ മാറ്റിയ കുഞ്ഞ് ഡെത്താവും. 2 ആഴ്ചയൊക്കെ കണ്ടിന്യൂ ചെയ്ത കേസുണ്ട്. അങ്ങനെ ആദ്യം അമ്മ കൺവിൻസ്ഡ് ആവും, പിന്നെ അച്ഛൻ കൺവിൻസ്ഡ് ആവത്തില്ല, അപ്പൂപ്പനും അമ്മ ഇടപെടും, ആകെ പ്രശ്നമാവും. അപ്പോൾ അങ്ങനെയൊക്കെയുള്ള സിറ്റുവേഷൻസ് വരുമ്പം പിന്നെ അവർക്ക് ഗിൽറ്റി ഫീലിംഗ് ആവും. സോ അതിനെക്കുറിച്ചൊക്കെയാണ് ആദ്യം പറഞ്ഞത്, എങ്ങനെയാണ് ഒരു ഡയഗ്നോസിലേക്ക് പോകാമെന്നുള്ളത്. ദെൻ ലേറ്റർ ഓൺ സാധാരണഗതിയിൽ നമ്മൾ കാണുന്ന ചില പ്രശ്നങ്ങൾ, കോൺഫ്ലിക്റ്റ്, ഭാര്യയും ഭർത്താവും തമ്മിലുള്ള പ്രശ്നമാവും, പിന്നെ അങ്ങോട്ടും ഇങ്ങോട്ടും പരാതി പറച്ചിലാവും, നീ കാരണമാണ് സംഭവിച്ചത്, അല്ലെങ്കിൽ നിങ്ങളുടെ കുടുംബത്തിൽ അങ്ങനെയാണ്, ഏതെങ്കിലും കുടുംബത്തിൽ ഏതെങ്കിലും ഒരു കുട്ടിക്കുണ്ടെങ്കിൽ അത് പ്രശ്നമാവും. സോ these are all real problems. Even though we know ഹൃദയം pays for the bill, ബാക്കിയുള്ള കാര്യങ്ങൾ എങ്ങനെ നടക്കും? ഇപ്പോൾ ചില സർജറിക്കൊക്കെ ഒരാഴ്ച ആശുപത്രിയിൽ പോയി സ്റ്റേ ചെയ്യേണ്ടി വരും, അല്ലെങ്കിൽ 2 ആഴ്ച നിൽക്കേണ്ടി വരും, ചിലപ്പോൾ 1 മാസം നിൽക്കേണ്ടി വരും. ബാക്കി അവരുടെ എക്സ്പെൻസസ് എങ്ങനെ മീറ്റ് ചെയ്യും? നമുക്ക് ചില അനുഭവം ഉണ്ടായിട്ടുണ്ട്. കയ്യിൽ 1 രൂപ പോലും ഇല്ലാതെ ആശുപത്രിയിലേക്ക് വന്ന ആളുകളുണ്ട്. 50 ദിവസം കഴിഞ്ഞ് 60 ദിവസം കഴിഞ്ഞ് ഡിസ്ചാർജ് ചെയ്ത് പോയ പേരൻസ് ഉണ്ട്. 50 ദിവസം അവരുടെ അതർ എക്സ്പെൻസസ് നമ്മുടെ ഈ പല ഹോസ്പിറ്റൽസും അത് പേ ചെയ്തിട്ടുണ്ട്. ചില ഹോസ്പിറ്റലിലൊക്കെ ചെല്ലുമ്പോൾ അവരവിടുത്തെ ഫുഡ് മൊത്തം കൊടുത്ത് അങ്ങനെ സ്റ്റേ ചെയ്ത പേഷ്യൻസ് ഉണ്ട്. അപ്പോൾ ഇതൊക്കെ എങ്ങനെ ഡീൽ ചെയ്യുന്നു എന്നുള്ളത് തീർച്ചയായിട്ടും നമ്മൾ അറിയേണ്ട കാര്യങ്ങളാണ്. ഓൺ ദ സെഷൻ പ്രത്യേകിച്ച് എന്തെങ്കിലും ഡൗട്ട്സ് ഇഫ് യു വാണ്ട് ടു ആസ്ക് ജെഫ്? ചില കാര്യങ്ങളൊക്കെ അവരുടെ ഒരു കോണ്ടെക്സ്റ്റിലാണ് ചില കാര്യങ്ങളൊക്കെ പറഞ്ഞത്, അവിടുത്തെ ഒരു കോണ്ടെക്സ്റ്റിലാണ്. പക്ഷെ അതൊക്കെ റിലവൻ്റ് ആയിക്കൊണ്ടിരിക്കുകയാണ്. എന്തെങ്കിലും കാര്യത്തിൽ പ്രത്യേകിച്ച് എന്തെങ്കിലും ഇഫ് യു വാണ്ട് ടു ആസ്ക് എനി ക്വസ്റ്റ്യൻ ടു ജെഫ് ഓൺ ദിസ്? Before one of the coming district on operate ചെയ്താണെങ്കിൽ we will not give. Okay, now Darshana will take you for another maybe 5-10 minutes on the story, and she will clarify 2 questions that somebody from there asked. Okay.
Thank you. ജെഫിന്റെ ക്ലാസ് കണ്ടപ്പോഴാണ് ഇതിനെക്കുറിച്ച് ഞാൻ നേരത്തെ കേട്ടിട്ടെങ്കിലും ഇത്രയും ഇമ്പോർട്ടൻ്റ് ആണ്, ശരിക്കും നമ്മളത് അറിഞ്ഞിരിക്കേണ്ടതാണ് എന്നെനിക്ക് തോന്നിയത്. മനസ്സിലായിരുന്നോ? ശരിക്കും വളരെ നമ്മളിതിൻ്റെ തിയറിയും നോളജും എല്ലാ കാര്യങ്ങളും നമ്മൾ മനസ്സിലാക്കുകയാണ്. പക്ഷേ ഈ മാനേജിങ് എ CHDക്ക് ഒരു വലിയൊരു ഇമോഷണൽ സൈഡ് ഉണ്ട്. അത് സത്യം പറഞ്ഞാൽ അത് അനുഭവിക്കുന്നവർക്ക് കണ്ടു നിൽക്കുന്നവരെ പോലല്ല, അനുഭവിക്കുന്നവർക്ക് അത് ഭീകരമാണ്. പിന്നെ ഇത് ജെഫിന്റെ ആ ടോപ്പിക് സ്റ്റാർട്ട് ചെയ്തത് പ്രീനേറ്റൽ ഡയഗ്നോസിസ് തൊട്ടിട്ടാണ് അല്ലേ? പോട്ടെ, ഒരു CHD ഇല്ല പ്രഗ്നന്റ് ആവുമ്പോൾ തൊട്ട് ബീങ് ഇൻ ദിസ് പ്രൊഫഷൻ എന്ന് വേണം ഞാൻ പറയാൻ അല്ലേ? ഈവൻ എനിക്ക് എൻ്റെ കുഞ്ഞാക്ക് ഇപ്പോൾ 1 വയസ്സാവുന്നേ ഉള്ളൂ, 1 വയസ്സായി. അപ്പം ഒന്നും ഇല്ലെങ്കിൽ പോലും എത്ര വട്ടം അനോമലി ചെയ്താലും ഇത് അനോമലി ചെയ്തത് ശരിയായോ, ആ റിസൾട്ട് ശരിയാണോ, ഇനി നമ്മൾ ഈ ഇതിൽ കാണുന്ന കുട്ടികളെ പോലെ ആരെങ്കിലും വരുമോ, എന്തുമാതിരി ടെൻഷനാണെന്നറിയാമോ അത്. എനിക്ക് ഇപ്പോഴും അത് ഓർക്കുമ്പോൾ വിഷമമാണ്. കാരണം എന്ന് പറഞ്ഞാൽ അതൊരു വല്ലാത്ത ഫീലിംഗാണ് അല്ലേ? അമ്മമാരായിട്ടുള്ളവർക്ക് എല്ലാവർക്കും അതറിയാം. ഇനി അങ്ങനെ ഉണ്ട്, എൻ്റെ കുഞ്ഞിന് ശരിക്കും അങ്ങനെ ഒരു പ്രശ്നമുണ്ട് എന്ന് ഒരു പ്രീനേറ്റൽ ഡയഗ്നോസിസ് പറഞ്ഞാൽ അവിടെ തൊട്ട് അത് ഭയങ്കരമാണല്ലേ. ഒന്ന് ഇതിപ്പോ ഒരു അബോർഷനുള്ളൊരു ചാൻസ് ഉണ്ട് എന്നുണ്ടെങ്കിൽ പിന്നെയും അവിടെ ഒരു ഹോപ്പ് ഉണ്ടെന്ന് പറയാം. സ്റ്റിൽ അങ്ങനെ ചിന്തിക്കുന്നത് ഒരു പക്ഷേ ഇതിൻ്റെ ബുദ്ധിമുട്ടും ഇങ്ങനൊരു കുഞ്ഞിനെ വളർത്തുന്നതിൻ്റെ കഷ്ടപ്പാടിനെ കുറിച്ച് നമുക്കൊരു പക്ഷെ അറിയുന്നത് കൊണ്ടാണ് നമ്മൾ അബോർഷൻ എന്നൊരു ഓപ്ഷനെ കുറിച്ച് ചിന്തിക്കുന്നത്. അതേസമയം ഒരു സാധാരണക്കാരിയായ അമ്മ അല്ലെങ്കിൽ ഒരു സാധാരണ വീട്ടിൽ സംബന്ധിച്ച് അവരൊരു പക്ഷേ അയ്യോ ഇത് പാപമാണ്, അങ്ങനെ ചെയ്യാവോ, അല്ലെങ്കിൽ ചിലപ്പോൾ അച്ഛനും അമ്മയും ഹസ്ബൻഡും സമ്മതിക്കുന്നില്ലായിരിക്കും, അല്ലെങ്കിൽ അമ്മ തന്നെ സമ്മതിക്കുന്നില്ലായിരിക്കും. അവരതിൻ്റെ വേറൊരു സൈഡിൽ ചിന്തിക്കും, അവർക്ക് ഇതിനൊരു കുഞ്ഞ് മുന്നേ പരിചയമില്ല. അതുകൊണ്ട് പക്ഷെ അങ്ങനെ ഒരാള് അതിൻ്റെ ഒരു റിയൽ ലൈഫിലോട്ട് ഒരാളെ കൈ കിട്ടിക്കഴിയുമ്പോഴാണ് അവരതിൻ്റെ ഒരു പെയിൻ മനസ്സിലാക്കി തുടങ്ങുന്നത്. ഇനി ഈ പറഞ്ഞ പോലെ ഒരു പ്രീനേറ്റൽ ഡയഗ്നോസിസ് നമ്മുടെ കയ്യിലുണ്ട്, പക്ഷെ ഒരു തീരുമാനം എടുക്കുക എന്ന് പറഞ്ഞാൽ ഇത് വേണോ വേണ്ടയോ എന്ന് തീരുമാനിക്കുന്നത് അതും ഭയങ്കര വിഷമമുള്ളൊരു കാര്യമാണ്. അപ്പോൾ ഇവിടെയൊക്കെ നമ്മുടെ റോൾ എന്താണ്? ശരിക്കും നമ്മുടെ തീരുമാനം അങ്ങോട്ട് പറഞ്ഞേൽപ്പിക്കുകയല്ല, അവരെ ഒരു ഡിസിഷൻ എടുക്കാൻ നമുക്ക് സഹായിക്കാം. പിന്നെ ഈ പറഞ്ഞ പോലെ സർ ഉദ്ദേശിച്ചത് ഇവിടെ പോസിബിൾ ആണോ എന്ന് പറഞ്ഞൊരു കാര്യം ഒരു സെൽഫ് ഹെൽപ്പ് ഗ്രൂപ്പിന്റെ കാര്യമാണ്. ശരിക്കും നമ്മൾ DICയിലൊക്കെ ഇങ്ങനെയുള്ള വൈകല്യങ്ങളുള്ള കുട്ടികൾ കുറേ പേര് വരുന്നുണ്ട്. അവരുടെ ഗ്രൂപ്പ് ഇപ്പോൾ ശരിക്കും അതിൻ്റെ ഒരു പ്രവർത്തനം കൊണ്ട് മാനസികമായിട്ട് ഒരുപാട് ശക്തരായ അമ്മമാരുണ്ട്. കാരണം നമുക്കൊരു കുഞ്ഞിനെ അങ്ങനെ കിട്ടുമ്പോൾ നമ്മുടെ ചിന്ത എപ്പോഴും പോകുന്നുണ്ട്, അയ്യോ എൻ്റെ എന്തോ കുഴപ്പം കൊണ്ടാണ് എനിക്ക് ഇങ്ങനെ വന്നത്, എനിക്ക് മാത്രമേ ഉള്ളൂ ഇങ്ങനെ ഒരു കുഞ്ഞ്, ഞാൻ ഒറ്റയ്ക്ക് വേണം ഈ കുഞ്ഞിനെ ഇനി ജീവിതകാലം മൊത്തം അല്ലേ, തീരുമോ ഇന്നോ നാളെയോ മറ്റന്നാളോ ഒക്കെ തീരും, അല്ലെങ്കിൽ നോർമൽ ഒരു കുഞ്ഞാണെ ശരി 3 വയസ്സ് കഴിയുമ്പോഴത്തേക്ക് നമുക്ക് സ്കൂളിൽ വിടാം, അങ്ങനെ ഇവർക്ക് ആശ്വസിക്കാൻ പറ്റുമോ? ഇല്ല. അപ്പം അവിടെ വേറൊരു അമ്മയും കൂടെ കിട്ടുവാണെങ്കിൽ എനിക്കൊരു കൂട്ടായി, ഒരു പക്ഷേ ഞാൻ ചെയ്യാത്ത എന്തെങ്കിലും പേരന്റിങ് കാര്യങ്ങൾ ആ അമ്മയ്ക്ക് അറിയാമെങ്കിൽ എനിക്ക് കണ്ടു പഠിക്കാം ഇല്ലേ? അത് ഒരു വലിയ ഹെൽപ്പാണ്. നമുക്ക് അങ്ങോട്ടും ഇങ്ങോട്ടും ഇവരെ പരിചയപ്പെടുത്തി കൊടുക്കാം. നല്ലൊരു ശീലം ഒരമ്മയിൽ കണ്ടാൽ നമുക്ക് മറ്റൊരു അമ്മയോട് പറഞ്ഞു കൊടുക്കാം, അല്ലെങ്കിൽ അവരെ പരിചയപ്പെടുത്തി കൊടുക്കാം. അതും ഒരു വലിയ കാര്യമാണ്. ഇവിടെയൊക്കെ നമ്മൾക്കുള്ള അറിവ് വളരെ സൂക്ഷിച്ച് മാത്രമേ ഒരമ്മയോട് പറയാവുള്ളൂ. നിങ്ങൾക്ക് അങ്ങോട്ടും ഇങ്ങോട്ടും ഷെയർ ചെയ്യാം, പക്ഷെ ആ പറയുന്ന അത്രയും കയറി ഒരു അമ്മയോട് പറയാവോ? ഇനി പറയുമെങ്കിൽ തന്നെ അതൊരു പ്രത്യേക രീതിയിലേ പറയാവൂ, ഒരു റിഹേഴ്സൽ എടുത്തിട്ട് സംസാരിക്കാവൂ. ഭയങ്കരമാണ് ആ ഒരു വിഷമം എന്ന് പറയുന്നത്. പിന്നെ ഓക്കെ, ഇങ്ങനെ ഒരു കുഞ്ഞിനെ കിട്ടി അതിനെ അക്സെപ്റ്റ് ചെയ്യുക, സമൂഹത്തിൽ അതിനെ മറ്റുള്ളവരോടൊപ്പം കൊണ്ടുപോവുക. പിന്നെ എനിക്കൊരു ഒരു കാര്യം തന്നെ, CHD അല്ല പക്ഷെ ഒരു ഡിഫക്റ്റ് ഉള്ളൊരു ബേബി, അതും ഇതുപോലെ അവർ അനോമലി സ്കാനിലൊന്നും അറിഞ്ഞില്ല. നമ്മുടെ SITയിലാണ് ആ കുഞ്ഞ് ജനിച്ചത്. കുഞ്ഞിനെ കണ്ട സത്യം പറഞ്ഞാൽ നമുക്ക് ഭയങ്കര വിഷമമാവും. ആ കുഞ്ഞിൻ്റെ ഇങ്ങനൊരു കുഞ്ഞ് ജനിച്ചത്, ഇത് പത്തനംതിട്ട ജില്ലയിൽ നിന്ന് വന്നൊരു ബേബിയാണ്. കണ്ടില്ലേ അതിൻ്റെ മുഖം? നമ്മളൊരു ഡെലിവറി കഴിഞ്ഞിട്ട് നമ്മൾ എങ്ങനെ ഒരു കുഞ്ഞിനെ പ്രതീക്ഷിച്ചിരിക്കുന്നത്? പ്രഗ്നൻ്റ് ആയിരിക്കും പോയി എൻ്റെ കുഞ്ഞ് വെളുത്തിട്ടാണോ ചെയ്തു. ആക്ച്വലി അവരിപ്പോൾ ഒരു കൗൺസിലിംഗ് സെഷനിൽ നമ്മൾ അവരെ ഒന്ന് ട്രാക്ക് ചെയ്യാൻ ശ്രമിച്ചുകൊണ്ടിരിക്കുകയാണ്. ഡൈവോഴ്സ് എന്ന് പറയുന്നത് എക്സാഗറേറ്റഡ് അല്ല. ഇങ്ങനെ ഒരു ഡിഫക്റ്റ് ഒരു ഡൈവോഴ്സ് എൻഡ് ചെയ്യുന്ന സാഹചര്യങ്ങൾ ഒരുപാടുണ്ട്. പിന്നെ വേറെ ചില സാഹചര്യങ്ങളുണ്ട്, ഇങ്ങനെ ഒരു കുഞ്ഞ് ആയ ശേഷം അച്ഛൻ ഉപേക്ഷിച്ച് പോവുക അല്ലെങ്കിൽ അമ്മ ഉപേക്ഷിച്ച് പോവുക, പിന്നെ ഒറ്റയ്ക്ക് ആ കുഞ്ഞിനെ നോക്കണം. ഇവർക്കൊക്കെ നമുക്ക് കൊടുക്കാൻ പറ്റുന്ന ഒന്നേ ഉള്ളൂ, മാക്സിമം സപ്പോർട്ട്. നമ്മളുടെ ഭാഗത്തുനിന്ന് നമുക്ക് കൊടുക്കാവുന്ന കാര്യം, നമുക്കറിയുന്ന കാര്യങ്ങൾ, നമുക്കറിയുന്ന സർവീസുകൾ. ഫൈനാൻഷ്യലി പ്രോബ്ലം ഉള്ളവർക്ക് ഹൃദ്യം എന്ന് പറഞ്ഞ പ്രോഗ്രാം ഒരു ബിഗ് സപ്പോർട്ടാണ്. പക്ഷേ എന്നാലും അവർക്ക് ഒരുപാട് സഹായങ്ങൾ ആവശ്യമാണ്. കൗൺസിലിംഗ് ആസ്പെക്ട് ഈ ഒരു കാര്യത്തിൽ അത്രമാത്രം ഇമ്പോർട്ടൻ്റ് ആയിട്ടുള്ള ഒരു കാര്യമാണ്. പിന്നെ ഡിപ്രഷനിലാവുന്ന അമ്മമാര് അല്ലേ, ഇതുമായിട്ടൊന്ന് അഡ്ജസ്റ്റ് ആവാൻ ഒരുപാട് സമയമെടുക്കും. നമുക്ക് ഒറ്റയ്ക്ക് ഇത് ഹാൻഡിൽ ചെയ്യാൻ പറ്റുന്നില്ലെങ്കിൽ ഒരു നല്ല കൗൺസിലറിന്റെ സഹായം വേണം. ചില ആൾക്കാർക്ക് ഒരു ഈവൻ ചിലപ്പോൾ മെഡിസിൻ വരെ വേണ്ടി വന്നേക്കാം ആ ഒരു ഇതിൽ നിന്ന് ഓവർകം ആയിട്ട് വരാനായിട്ട്. അപ്പോൾ നമ്മുടെ റോൾ ഒട്ടും കുറച്ച് കാണരുത്. ദാൻ ഗിവിങ് എ നോളജ്, ഈ ഒരു പാർട്ട് എന്ന് പറയുന്നത് ഭയങ്കര ഇമ്പോർട്ടൻ്റ് ആണ്. അപ്പം ഒത്തിരി സമയം ഞാൻ എടുക്കുന്നില്ല. ഞാൻ പറഞ്ഞപ്പോൾ ഞാൻ 1-2 കാര്യങ്ങൾ നോട്ട് ചെയ്താണ്. അതുപോലെ ഈ കുഞ്ഞുങ്ങളുടെ വളർച്ച, ഈ കുഞ്ഞൊന്നല്ല നോർമൽ കുഞ്ഞിൻ്റെ തന്നെ വളർച്ച, നമുക്ക് അടുത്തുള്ള ആ പ്രായത്തിലുള്ള ഒരു കുഞ്ഞിൻ്റെ അത്രയും എൻ്റെ കുഞ്ഞായില്ലെന്നുണ്ടെങ്കിൽ നമുക്ക് എന്നും അതൊരു ടെൻഷനാണ്. അപ്പം ഇങ്ങനൊരു അസുഖമുള്ളൊരു ബേബീൻ്റെ ആകുമ്പോൾ അത് ഒന്നും കൂടി ആയിരിക്കും. അവിടെയൊക്കെ നമുക്ക് ശരിക്കും സപ്പോർട്ട് ചെയ്യാമല്ലോ അല്ലേ. ആ ഒരു ഗ്രോത്തിലോ ഡെവലപ്മെന്റിലോ പുറകിലോട്ട് പോകുന്ന കുഞ്ഞുങ്ങളെയൊക്കെ നമുക്ക് സപ്പോർട്ട് ചെയ്യാം. അപ്പോൾ നമ്മുടെ ഭാഗത്തുനിന്ന് ആ രീതിയിലുള്ളൊരു എഫോർട്ടും കൂടെ നന്നായിട്ട് ഉണ്ടാവണം. അത് ഞാൻ പറഞ്ഞ പോലെ റിഹേഴ്സൽ എടുത്തിട്ട് വേണം ഒരു പേരൻറ്റിനോട് സംസാരിക്കാൻ. അത്രയേറെ ഇമ്പോർട്ടൻ്റ് ആണ് ഈ ഒരു ഫീൽഡ്. കാരണം നമ്മൾ കൊടുക്കുന്ന ഇൻഫർമേഷൻ ഒരു പക്ഷെ അയ്യോ അങ്ങനെ പറഞ്ഞു, നമ്മൾ വെറുതെ പറഞ്ഞിട്ട് പോയി, അവർക്കത് പാവപ്പെട്ട് അവർ ആലോചിക്കും. അപ്പോൾ ഓർക്കുക, നമുക്കത് ഓർത്ത് ശ്രദ്ധാപൂർവ്വം നമുക്ക് ഈ ഒരു കാര്യത്തിൽ പ്രവർത്തിക്കണം. താങ്ക് യു. എന്തെങ്കിലും ചോദിക്കാനുണ്ടോ ജെഫ്? നമ്മുടെ സംശയങ്ങൾ എന്തെങ്കിലും ഉണ്ടെങ്കിൽ ക്ലിയർ ചെയ്യും. സാറ് മുമ്പേ പറഞ്ഞ പോലെ ഇങ്ങനെ എന്തെങ്കിലും സാഹചര്യം നിങ്ങൾക്ക് ഉണ്ടെങ്കിൽ ആ സാഹചര്യം അല്ലെ അവിടെ ഞാൻ എന്ത് പറയണം എന്നൊരു കൺഫ്യൂഷൻ ഉണ്ടെങ്കിൽ ചോദിക്കാം, അത് നമുക്ക് ക്ലാരിഫൈ ചെയ്ത് തരും. അതല്ലെങ്കിൽ ഓക്കെ, താങ്ക് യു.
So while they're setting up my slides, I wanted to echo some of the things that Jeff said. You know, I went into pediatrics because I love children, and I'm sure that that's why you are all here as well. And I went into cardiology because these were children who had conditions that by and large we could fix. And so it was an opportunity to make a huge difference. But one thing I learned early on was that I didn't just have one patient. I usually had 3. I had the child and the parents. And there's little that gives me more pride than when I have successfully connected with a set of parents and helped them through a very difficult time as well. But I realized that as a doctor, I'm very limited. I have limited exposure. The family has come some distance to see me, and then they are gone. Generally speaking, people are reluctant to talk to doctors. They're frightened of us. And they talk to nurses much better. You guys have the opportunity to get into their homes and to get into their lives in a much more meaningful way than I can do. And I am so grateful for the presence of this program that has you nurses being the eyes and ears for the medical establishment. So before I go any further in this, I want to thank you for being here today. Let's continue. This is the same talk before, but now I'm going to be discussing specifics regarding critical congenital heart disease. Let's talk about transposition of the great arteries first. And for those of us at the treatment centers then, and the physicians, we have to consider when is it troublesome or dangerous. And for transposition, the problem is right there at birth. Before birth, when circulation doesn't depend on the lungs and oxygenation doesn't depend on the lungs, these babies do just fine. And the majority of transposition babies don't have other problems either. But at birth, they suddenly turn blue, and unless there is an accompanying atrial septal defect or ventricular septal defect, their cyanosis will be intense and they're in deep trouble. So the first step after making a diagnosis is to palliate with prostaglandin, as you know, and follow the saturations. And I do need to mention, although this won't be your concern, that on rare occasion, prostaglandin can make things worse. If you think about the physiology that was discussed earlier, where these babies are blue because oxygenated blood isn't getting out to the body, if you keep the ductus open, the ductus arteriosus, that will send blood from the blue aorta into the red pulmonary artery and put more blood into the lungs. This high flow can push the flap of the foramen ovale closed and cause pulmonary edema. So prostaglandin does have risks besides what I mentioned earlier this morning about fever and apnea. So we don't use prostaglandin lightly. The next step, once you get the child, once you get the baby settled, is to schedule the arterial switch operation. And you generally want to do that within a week before left ventricular pressure falls and the ventricle gets too weak. One considers a balloon atrial septostomy or Rashkin procedure if the surgery is delayed or if the baby's saturations are unacceptable even with prostaglandin and you need to get the baby in good shape before going to the operating theater. And you already know the anatomy, I won't show that again. But maybe I should mention here again, so the ductus arteriosus is open, but is going to flow from blue blood to red. That doesn't help the baby. But what does help the baby is that all this increased flow coming back from the lungs to the left atrium increases the amount of leakage left to right. This again shows the balloon septostomy. The picture that Anu showed earlier today was a lovely picture, but it gives no idea of just how big this balloon is. So here is the balloon coming up from the femoral vein, crossing the foramen ovale. It is then inflated and pulled back. In real life, it looks like this. It's enormous. Here it is sitting on the left side, and this is after it's pulled back and is now resting at the inferior vena cava. And then we proceed with the arterial switch operation. It's a complicated operation. And in the initial days of open heart surgery for babies, in the early 60s when people started inventing operations to correct congenital heart disease, they thought for transposition it should be easy. You just switch the arteries back to where they belong. What they weren't prepared for is that they also have to move these coronary arteries from the old aorta to the new aorta. And in the early 60s, they hadn't yet even invented coronary bypass surgery, or CABG. So surgeons really had no understanding or experience in small vascular surgery. So in the 1960s, arterial switch operations always failed. The other problem was that in the early 60s, we didn't have equipment small enough to do neonatal surgery. And so any attempt at surgery was postponed until the child was 3 or 4 or 7 years old. And at that point, the left ventricle was too weak to sustain systemic pressures anymore. And so initial attempts at arterial switch operation all failed. The babies died on the operating room table. They never came off. Once surgeons had developed the ability to move coronary arteries and to do infant surgery, suddenly we were able to revive arterial switch. But in the meantime, the atrial switch operation, the mustard operation or the Senning operation were invented in the 60s, and these babies would have that repair and do pretty well for most of their lives. They did have problems with progressive right ventricular failure and with arrhythmias, and that's why we returned to the idea of arterial switch. So for one reason or another, there are babies who go home from the hospital without an operation, and suddenly this is now your job. So let's talk about disease-specific preoperative things that we want you to watch for. Transposition babies not operated in the first week of life generally have a VSD. Or they have had a Rashkind procedure, a balloon septostomy. One way or another, they have adequate mixing, so their saturations aren't too bad, but they may develop high flow to the lungs and develop signs of congestive heart failure. Rapid breathing, fast heartbeat, large liver, and those are the things that you will want to watch for. If, however, their VSD begins to close, they may get progressively blue. And so to the extent that you are able to follow their saturations, that's something that will be useful. Once they have had an operation and they come back to you, disease-specific complications that we would ask you to watch for are kinking of the coronary arteries. Now that's something you obviously can't see, but it's a tricky thing, a tricky maneuver for the surgeon to move those vessels. Occasionally they can kink and they can occlude, and so the child will have angina. And what you may see is a baby who is crying, obviously in pain, but in a pain that is real. And you know the difference between a baby who can be soothed with a nipple and the baby who is really in pain. Also, the baby will be pale and sweaty, and those may be signs of a coronary problem that requires immediate attention. Also, the characteristics of the arterial switch operation put tension on the main pulmonary artery, and it is relatively common over time for that vessel to narrow. And the major cause of reoperation in an arterial switch operation is to enlarge and relieve the pressure and the tension on the main pulmonary artery. This takes place over years, but would present to you as a murmur that's getting progressively louder over the pulmonary artery. It occasionally happens that the recurrent laryngeal nerve, a nerve that comes down from the neck, passes under the aorta and near the ductus arteriosus, and then back up to the vocal cords, that may get injured, and the baby will be hoarse. You will notice a very, very soft voice even when the baby is crying. And the practical implications of that is that then the baby is unable to fully protect the airway when eating. They won't be able to close their vocal cords, and so the possibility of aspiration is increased. So you'll want to be careful and find out if the baby has a hoarse voice and is choking. And then finally, in working in the chest, it's sometimes possible to damage the phrenic nerve that controls the diaphragm. And hopefully this will be recognized before the baby goes home. The chest x-ray will not show the diaphragms at an equal level, but they will show one diaphragm down and the other one up. You may be able to detect that on your examination, because a child with a paralyzed diaphragm, when they take a breath, one side goes down, one side goes up, and the chest movement will be asymmetric. Instead of the chest expanding, it'll be like this, a little seesaw. Let's move on to TAPVC. Again, when is that troublesome or dangerous? Again, at birth due to hypoxemia. However, if it's unobstructed, then those babies will fairly quickly pink up. And they may get so pink that the amount of cyanosis will be imperceptible. They still have an obligatory right to left shunt. All of their blood, all the blood passing to the left atrium must include some blue blood. But it may be such a small proportion that you won't be able to see. That would be the best situation, and those children can wait and should wait for repair until they're a bit older. So those are the ones who will come home to see you. But for us in the hospital, if the cyanosis is terrible and it doesn't get better and is in fact worsening despite our measures, they go straight to surgery and get repaired. The next step as I mentioned below, if they're getting worse, operate soon. If moderately obstructed, you can take your time a little bit, and if unobstructed, you can wait for quite some time and perhaps get a better repair. So if the baby has not received an operation and has come out to the community, the things we would want you to watch for are that, again, unobstructed babies may go home and be followed clinically, but they may progressively develop heart failure due to high flow. So again, watch for rapid breathing, sweatiness, fast heart rate, big liver, and those children are fairly easily treated with anticongestive medications like diuretics until it's time to repair them. Following surgery, now they've been repaired and they come out to the community, the main thing that all of us need to be worried about is that the connection the surgeon has made between the pulmonary veins and the left atrium may scar down and get smaller, or at the very least may not grow as rapidly as the rest of the baby and the heart. And so it will be progressively obstructed again. It will seem narrower and narrower. And in that situation, again, you will see signs of heart failure, this time not because of high flow to the lungs, but restricted flow out of the lungs that will cause fluid to back up in the lungs and cause that congestion. We didn't talk about Truncus Arteriosus today. I think that was on the list of critical heart diseases that we didn't get to. I was going to skip it. Dr. Srihari wanted me to mention it anyhow because you will be discussing this at later sessions. So Truncus Arteriosus is a condition in which, let me back up. In embryologic development, our hearts start with just one main artery leaving the heart. And over time, this artery is supposed to pinch off into two. And so imagine, I'm going to put this down for a second. One big tube that then pinches down and becomes two. One of them is posterior, and that's the aorta, and the other is anterior, that becomes the pulmonary artery. And Truncus arteriosus is the condition where that septation, that wall between the two arteries, has failed to develop, and now you only have one artery. This condition is always accompanied by a ventricular septal defect underneath this big artery, so both ventricles eject their flow into one artery. Once this artery leaves the heart, it sends branches to the body like an aorta, but it also sends branches to the lungs. And there are several varieties depending on how those lung vessels arrive. In any case, those children will be blue, will have cyanosis because their red blood and blue blood are forced to mix together. There's an obligatory right to left shunt. All the blood in the right ventricle gets pumped into this aortic sort of vessel. But there's also an obligatory left to right shunt because all the flow coming back to the left atrium winds up in this common artery that also goes to the lungs. So at birth, these children usually are blue, but because of progressively increasing flow to the lungs, their cyanosis may become imperceptible. And these children are prone to developing substantial degrees of heart failure. For them, the first step is to establish the diagnosis and look for associated diagnoses. In particular, interrupted aortic arch sometimes occurs. And then observe for respiratory trends. The next step is to observe their breathing patterns and weight gain, but these children typically are not repaired right at birth. They will develop heart failure so rapidly that they generally are repaired by 3 months of age. The chances are good that these babies will spend some time in the community before their operation. In that situation, we would want you folks to specifically watch for progressive heart failure and as a consequence, poor feeding, poor growth, poor weight gain. After these children have a repair, the repair consists of closing the ventricular septal defect in such a way that this truncal artery is now connected solely to the left ventricle. And the pulmonary arteries are detached from this vessel and connected to the right ventricle by a tube, a conduit, a homograft usually, or something made of Dacron. And the surgeon will put in the biggest one they possibly can in this little baby, but inevitably it will be too small for a full-size child. And so eventually the child will outgrow this artificial pulmonary artery that connects the right ventricle to the lungs. That's the second thing down there, is that the right ventricle to pulmonary artery conduit will become stenotic and or leaky and eventually need repair. And again, you'll notice that by progressively louder murmur. The first thing is that the valve in this truncus is not a normal aortic valve. Instead of 3 leaflets, it may have 2 or as many as 4 or 5 leaflets. And it almost always is a little bit sticky and a little bit leaky. Over time, it could become a lot stenotic and a lot leaky, and in many cases requires replacement as a subsequent procedure. So that's what we need you to look for is, again, signs of failure, or in this case, insufficiency of the truncal valve. And I think finally we'll be talking about coarctation today. Again, you've learned today that it is troublesome within hours or days of birth. Once the ductus arteriosus closes, reducing blood flow and pressure in the lower body. So the first step is to establish the diagnosis, look for associated lesions, since at least 50% and in many cases close to 90% of coarctation babies will have associated lesions. And you'll want to initiate prostaglandin to widen the aorta and get a little flow until you can get to the operating room. Corrective surgery is generally done within days, and catheter procedures in a baby who is sick, who maybe has an infection, who is too small for surgery. There are palliative catheter procedures you can do. You wouldn't stent a newborn, but you could at least dilate the vessel and buy some time until repair is available. I also wanted to mention in the earlier session on coarctation, I think somebody asked about whether or not the balloon procedure would occlude that artery and damage the lower vessels, or even more important, whether the surgical correction, when the artery is actually cut open and we're removing the narrowed part, what does that do to blood flow in the belly and in the kidneys? And how does the baby tolerate that? And the first part of that answer is that fortunately the kidneys are more forgiving than the heart or the brain. If you cut off blood flow to the brain for more than a couple of minutes, you would have serious consequences. So the lower half of the body does tolerate low flow a bit better. But more importantly, blood always tends to find a way in the human body, and we do have, in the case of coarctation, collateral vessels, small vessels that arise from the intercostal arteries that bypass the coarctation, so that even when you clamp off the aorta for the repair, there is still a low amount of flow heading to the abdomen to keep those vessels alive. But I will also mention that there's still some damage in those procedures, and in the early days of coarctation repair, occasionally some of the spinal arteries might be damaged in the repair. It was a rare complication, but still not completely forgotten, that some of these babies after an operation would be paraplegic, that that their spine would be injured. In any case, looking at the children who go home before a coarctation repair, if for some reason they've simply been palliated and not yet repaired, mild cases may have surgery postponed for years, or waiting until they're old enough and big enough for a catheter and stenting procedure. Uncorrected babies still require constant surveillance, since the obstruction may get worse. And I will also mention that close to 90% of babies with coarctation also have bicuspid aortic valve. And although that's a common malformation in the community, 25% of people with bicuspid aortic valve will require an intervention on that sometime in their lives, either because of aortic stenosis or insufficiency. In the case of babies who have had their coarctation operation, the complications we want you to be looking for are incomplete relief of obstruction or recurrence of obstruction, where once again the pulses are poor in the legs or absent. You saw a picture of an aneurysm. Those develop late after repair, and that's not really something you will be able to detect because I don't think most of you have X-ray vision. But that's something that we all have to be concerned about. I have seen children have surgery for coarctation in which the surgeon inadvertently ligated the wrong vessel. Instead of ligating the ductus arteriosus, ligated the pulmonary artery, or even the descending aorta. So again, you'll be wanting to check the pulses and listen for murmurs. As with the arterial switch operation that I mentioned, we'll look for recurrent laryngeal nerve injury with vocal cord paralysis, a hoarse voice, and possible aspirations, phrenic nerve injury, and particularly since the coarctation operation is in the left chest, there's the possibility of pneumothorax or hemothorax, in which case your breath sounds will be diminished. I'm done talking. Thank you for your attention.
താങ്ക് യു ഡോക്ടർ പീറ്റർ. നമ്മൾ ക്രിട്ടിക്കൽ കൺജനൈറ്റൽ ഹാർട്ട് ഡിസീസിനെ കുറിച്ചുള്ള ഒരു സെഷനായിരുന്നു. നിങ്ങൾക്ക് മനസ്സിലായോ? ഇത്തിരി പാടാണ്, എന്നാലും ഏകദേശം ഓക്കെ. അപ്പോൾ ഞാനാണെങ്കിൽ മുമ്പ് ചോദിച്ച ആ ഡൗട്ട് ഉണ്ടായിരുന്നല്ലോ, അതായത് സംശയം ഇതായിരുന്നു, നമ്മൾ സ്റ്റെൻറ്റിങ് പ്രൊസീജിയർ ചെയ്യുമ്പോഴോ കോയാക്ടേഷൻ ഓഫ് അയോട്ടയുടെ സർജറി ചെയ്യുമ്പോഴോ അയോട്ടയുടെ ബ്ലഡ് ഫ്ലോയിനെ ക്ലാമ്പ് ചെയ്ത് തന്നെ നമുക്ക് സർജറി ചെയ്യാം, ഒരു പ്രശ്നവും